For many women, pregnancy is a time of hope, excitement, and change. But for those living with antiphospholipid syndrome, APS, it can also be a time of anxiety and uncertainty. APS is an autoimmune condition where the immune system mistakenly attacks normal proteins in the blood, leading to blood clots and, in many cases, complications during pregnancy. It's one of the leading causes of recurrent pregnancy loss that often goes undiagnosed until after one or more miscarriages occur. Historically, treatments like low-dose aspirin and heparin, a blood thinner, have helped many women with APS carry pregnancies to term. However, they're not always effective, especially in cases where APS causes inflammation beyond just blood clotting or when symptoms don't fit the typical diagnostic criteria. That's where biologic therapies come in. These are advanced medications that target very specific parts of the immune system, and they're starting to show real promise in improving pregnancy outcomes for women with complex or treatment-resistant forms of APS. Let's take a look at how these therapies work and what hope they're offering to women who've faced heartbreaking pregnancy losses due to this condition. First, it helps to understand what's going on in the body when someone has APS. This syndrome causes the immune system to create abnormal antibodies, particularly antiphospholipid antibodies, that make blood more likely to clot. During pregnancy, this can interfere with the placenta, restrict blood flow to the fetus, and lead to miscarriage, stillbirth, or complications like preeclampsia. Doctors typically treat APS in pregnancy with a combination of low-dose aspirin and heparin. This approach works well for many, but not all. Some women still experience miscarriages or other complications even while on treatment. Others may have seronegative APS, where all the signs are there, but the standard antibody tests come back negative. These cases don't always respond to traditional blood thinners, which has led researchers to explore other ways to tackle the problem, especially by looking at the role of the immune system itself. Biologic therapies are medications made from living organisms that target specific immune system components. Unlike general immunosuppressants, which blunt the whole immune response, biologics are designed to go after just one molecule or cell type that's causing the issue. In APS, several biologics are now being studied for their potential to reduce clotting, calm inflammation, and improve pregnancy outcomes. Here are some of the main ones being explored. Rituximab. This biologic works by targeting B cells, a type of white blood cell that produces antibodies, including the harmful antiphospholipid antibodies. While rituximab is mainly used for diseases like lupus and certain types of cancer, it's been used off-label in women with severe or refractory APS, especially when other treatments have failed. Some case studies suggest it may help reduce antibody levels and calm immune overactivity during pregnancy. Eculizumab. This one's a bit more specialized. It blocks a part of the immune system called the complement system, which can become overactive in APS and lead to inflammation and clotting in the placenta. Eculizumab has been life-changing for patients with rare blood disorders, and though it's very expensive, it's shown potential in pregnant women with catastrophic or severe APS, especially when there's a high risk of organ damage or preeclampsia. TNF-alpha inhibitors, drugs like infliximab and adalimumab, which are often used in rheumatoid arthritis and Crohn's disease, block a molecule called tumor necrosis factor alpha, TNF-alpha. This molecule plays a role in inflammation and has been linked to poor placental development in APS. There's limited but growing evidence that TNF inhibitors may help some women with non-criteria obstetric APS, cases where the typical blood tests don't pick up the disease, but pregnancy complications keep occurring anyway. Hydroxychloroquine, yes, technically not a biologic, but often included in discussions originally used to treat malaria, hydroxychloroquine is now a staple in managing autoimmune diseases like lupus. It's not a biologic in the strict sense, but it does have immune-modulating properties, and several studies have found that it improves outcomes in women with APS, especially when combined with standard therapy. Why this matters for women with APS? For years, many women with APS who lost pregnancies felt like they had no answers. Some were told it was just bad luck, while others were told their test results didn't meet the criteria for diagnosis, even though they were showing clear signs of APS-related complications. Biologic therapies may finally offer a new layer of hope, especially for those who've already tried traditional treatment and still experience loss. By targeting the immune system more precisely, These medications could reduce inflammation, lower antibody levels, and improve blood flow to the placenta. In other words, they may create a safer environment for both mother and baby. Of course, these treatments aren't without risks. Many biologics suppress parts of the immune system, which could raise the chance of infections. And because most biologics haven't been widely studied in pregnancy, their long-term effects on both mother and child are still being monitored. Most of the data we have so far comes from small case reports or pilot studies, not large-scale clinical trials. But the early results are promising, and more research is underway. A new era in APS pregnancy care. The world of autoimmune medicine is changing fast. Biologic therapies, once reserved for the most severe cases of disease, are now being used to treat previously untouchable problems, like recurrent pregnancy loss in women with antiphospholipid syndrome. For those who've experienced the heartbreak of miscarriage after miscarriage, and for the doctors trying to help them, biologics represent more than just a new type of medication. They're a symbol of hope. Hope that with better understanding and more targeted treatments, women with APS can have healthy pregnancies and bring home the babies they've long dreamed of. There's still a long road ahead, and these treatments aren't a magic bullet. But they're a step forward, and for many women, that step could make all the difference. A clinical trial co-led by the Hospital for Special Surgery, HSS, has found that blocking inflammation with the drug certolizumab significantly reduces the risk of serious adverse pregnancy outcomes in women with antiphospholipid syndrome, APS. The Phase 2 IMPACT trial, Improved Pregnancy in APS with Certolizumab Therapy, was co-led by Janie Salmon, MD, a rheumatologist, and the Colette Keene Research Chair at HSS&D Ware Branch, MD, an obstetrician/gynecologist at University of Utah Health. It is the first clinical trial to evaluate a biologic therapy to prevent serious adverse outcomes in pregnant women with APS and their babies. The study results were published online on April 10, 2025 in Annals of the Rheumatic Diseases. The IMPACT study represents a bold and very successful partnership over many years between government, industry, foundations, and academic health research institutions, said Dr. Salmon, the senior study author. It is exciting to see our preclinical work in the laboratory, which began more than a decade ago, translate into such promising results for patients. I hope our findings will allow the drug to become widely available so that more pregnant women with APS and high-risk pregnancies can benefit. APS is a rare autoimmune disorder affecting up to 0.05% of people. It is frequently associated with lupus, a disease most prevalent in women during their reproductive years. In APS, the body produces autoantibodies that react with blood vessels and circulating cells, causing dangerous blood clots throughout the body, which can lead to strokes, heart attacks, and phlebitis. During pregnancy, APS raises the risk of serious complications arising from issues with the placenta, including fetal death, preeclampsia, and restricted fetal growth. Previous research led by Dr. Salmon identified lupus anticoagulant, LA, an autoantibody produced by some APS patients, as the strongest predictor of poor pregnancy outcomes in APS patients. Historically, 39% to 86% of pregnant women with APS who are LA positive have faced severe complications, despite treatment with standard of care blood thinners like heparin and aspirin. These patients have the greatest need for better treatments. Dr. Salmon's preclinical research in experimental models showed that inflammation in the developing placenta, not blood clots, was the main cause of pregnancy complications in APS. This pivotal discovery led her team to investigate whether TNF-alpha inhibitors, a class of drugs used to treat inflammatory conditions like rheumatoid arthritis, Crohn's disease, and plaque psoriasis, could offer better protection to APS pregnancies than blood thinners alone. The IMPACT trial enrolled 51 pregnant women ages 18 to 40 with high-risk APS, defined as positive for lupus anticoagulant. All participants were treated with certolizumab, a TNF-alpha inhibitor that does not cross the placenta, in addition to standard of care heparin and aspirin, starting at week 8 of pregnancy. Medication was stopped at week 28, the point at which the placenta is well developed. The unique design of the IMPACT study made it possible for pregnant patients from 16 states and 1 Canadian province to participate. The 20% complication rate in patients treated with certolizumab was dramatically lower than their prior pregnancies, in which 69% to 79% had severe adverse outcomes, despite standard treatment with heparin and aspirin. The average gestational age at delivery was 36.5 weeks in certolizumab-treated pregnancies, compared to 24 weeks in patients' prior pregnancies. Among IMPACT participants, 93% brought home a healthy baby, a remarkable improvement over the 38% survival rate for their previous pregnancies. Notably, none experienced serious infections or lupus flares, a concern when the study began. The trial supports the concept derived from basic laboratory studies that targeting inflammation, rather than blood clotting, is effective in preventing pregnancy complications in high-risk pregnant patients with APS. It also shows the power of collaboration between rheumatologists and obstetricians.